Hello, I'm Imani LaGrone.
And I'm Sammy Seibel. And we will be presenting on CSF and blood levels of GFAP in Alexander disease. And CSF stands for cerebrospinal fluid, and GFAP is a protein which we will be discussing.
So, Alexander disease is a neurodegenerative disorder that is often classified as a leukodystrophy disorder, and so those are generally disorders where the myelin is degenerated, and so in this disorder they have three different classifications. They have the infantile form, the juvenile form, and the adult form. And generally the infantile form, there are different signs that are generally not as mild, are generally a little bit more milder than the later onset ones, but they have enlarged brain and head sizes. They oftentimes have different seizures, and they have lots of motor disabilities, so they have stiffness in the arms and legs, and they often have intellectual disabilities, and it's often associated with mental retardation. In the juvenile and the adult forms, they have more things like speech abnormalities, they have difficulty swallowing, and they also have seizures that are more advanced, and they also have poor coordination of their mobility. And then they, in this disorder, they have different protein deposits that are called Rosenthal fibers, and they are astrocytes, which are glial cells that are in the central nervous system that help support the nervous system. And then this disorder is pretty rare. It's not known how prevalent it is, but since 1949, when it was kind of discovered, there have been about 500 cases.
So Alexander disease is a progressive, generally fatal neurogenetic disorder, and it is a result of heterozygous dominant mutations in the protein GFAP, which stands for glial fibrillary acidic protein. And so what a heterozygous dominant mutation means that you only need a mutation in one of your two alleles in order to have this disorder. And so if you were to have the mutation in two alleles, in order to have that, it would be recessive, but you only need one. Therefore, this is a heterozygous dominant mutation. And the hallmark feature, as Imani already mentioned, is the Rosenthal fibers, which are GFAP aggregates in the cytoplasm of astrocytes. And you can see them here in this picture. It's the darker pink magenta-like structures. And so those are the Rosenthal fibers. And unlike other mutations, the GFAP mutation is actually a gain-of-function mutation. And so in typical mutations, if you could say there is a typical mutation, they usually have loss of function, meaning that they stop producing protein or the protein is no longer effective. But in a gain-of-function mutation, more protein is produced or it's more effective in what it does. And currently there are no treatments for Alexander disease, but several strategies are being pursued, such as suppression of the expression of GFAP. But the issue with this is there's no way to assess the efficacy of these treatments. And so, although Alexander disease patients are genetically homologous, the classification system is also lacking, and patients are typically classified by their age of onset, so either juvenile, infantile, or adult. And so part of this issue is there's no way to evaluate the severity or the progression of the disease, and so there's no better way to classify these patients. And so because of this, the authors point out a clear need to identify and evaluate biomarkers so that we can evaluate the severity and progression of Alexander disease. And also, if we have a biomarker, this will be useful in determining the effectiveness of treatments and if they work or if they don't work. In previous studies have found that GFAP levels are increased in the CSF and blood of Alexander disease patients. And one important study that the study we're looking at focused on was a study by Keller et al., which reported elevated GFAP levels in the CSF samples of 3 Alexander disease patients. And so what the authors of this study wanted to do was they wanted to replicate Keillerman's study, but with a larger cohort of patients to hopefully confirm the results and even find an accurate biomarker. Okay, so on to the methods. So for the CSF samples, the authors were only allowed to use samples from previous clinical uses, And then for the control samples, they collected 24 de-identified samples by lumbar puncture, which were collected from healthy adults of both sexes. And these adults were also asked to exclude themselves if they had specific conditions, such as neurologic conditions or brain trauma. And they were also asked to exclude themselves if they were taking a specific medication. And then for plasma preparation, they collected blood in a tube with anticoagulant to prevent clotting. And then they centrifuged this sample, and they collected the supernatant. And then they stored the supernatant either on dry ice or at negative 20 degrees Celsius until the samples could be shipped. And then upon delivery, they were thawed, divided into aliquots, and then stored at negative 80 degrees Celsius until further analysis. And so then next was the quantitation of GFAP. And they did this using a sandwich ELISA, which this picture shows how that works. It's through the use of antibodies and conjugate proteins so that you can quantify how much of a protein is present. And then they also generated standard curves using bovine samples. And then they also pointed out that the biological limit of detection of GFAP was 46 nanograms per liter. And so then I will mention this shortly in the statistics section. And so for the statistics, the results were summarized using ranges and medians. The samples yielding values lower than the biological limit of detection were treated as censored values. And so due to the presence of censored values, they conducted a semi-parametric quantile regression. And then they also used a non-parametric Wilcoxon rank sum test to compare the GFAP levels between Alexander disease patients and control subjects, as well as to compare subgroups. And then finally, they applied a SIDAC correction when performing multiple comparisons.
So on to the results. So they had the results broken up into different sections. The first section was the patient population. So they used like two general samples. The first was the leftover clinical CSF samples, and that generally had 5 females and 7 males, and they had an age range between 4 and 46. And then the blood samples that they used, they had 26 females and about 22 males, and they had an age range that was less than 1 to about 65. And then they also had 10 patients that they used both the CSF and the blood samples from. And then here's a table that outlines all the different patients. The next section was the GFAP levels in the CSF. And so they had 10 patients that had the Alexander disease that were compared to 12 controls. And as you can see based on this graph, the controls generally had lower GFAP levels in comparison to those with the Alexander disease. And as Sammy mentioned, they had measured these in the median and the range. The next section was the GFAP levels in the blood. And so they had a sample size of about 111, and only about half of those were detectable samples. And so in the control, they saw that there were no extreme differences as far as the GFAP levels, which you can see here in this graph. The levels are kind of low, and they're all about in the same range. And then looking specifically at the Alexander disease patients, mainly the infantile had the greatest elevated GFAP levels in comparison to the control, as well as the other forms of the Alexander disease groups. And then looking at the CSF and the blood samples of those 10 patients, they noted that the CSF levels were greater than the blood levels, but the blood levels were higher when there was a 95% CL only when the CSF levels exceeded a certain threshold. And that goes into the next section, which talked about the GFAP levels in relation to the clinical features. And so as you can see on this graph, generally the CSF levels of the GFAP are higher than the blood levels, which correlated with the last section. And so specifically in here, they had 12 patients that were the CSF patients, and then 10 samples had a lot of different mutations, and 2 specifically had 2 specific mutations, and they wanted to point out which mutations may have correlated more with this disease. And then looking at the blood levels, they had 4 to 6 patients with 5 specific mutations. And they noted in here how the GFAP levels correlated with two things: the age of the illness, so if someone had the disorder for about 3 years, as well as the age of the sample collected. So if someone was in the infantile stage, they were trying to see if that correlated with the age of the illness. And then they also looked at 2 additional samples that had a specific mutation, the R239H, and they noted that that mutation specifically had a lot of correlation with the disorder. And so, as I touched upon before, they talked about how the GFAP levels in the CFS patients were higher than those in the controls in all of the Alexander disease patients. Also, the GFAP levels in the blood samples were higher than those in the control in the infantile and the juvenile patients. And they also wanted to look at the CSF levels and how those were significantly elevated in comparison to those with the Alexander disease if they had been more or less than 4 years, but the blood levels were only significant in patients that had the disease for less than 4 years, excuse me.
Okay, so on to the discussion. So ultimately, these authors found that their results supported and confirmed Keilerman's study that GFAP levels in the CSF were consistently elevated. However, the reason for this is not clear. They also found that GFAP levels were higher in infantile and juvenile onset patients compared to adult onset patients. And the reason for this is also unknown, but previous studies on mice suggest that there is a linear relation between levels in parenchyma, which are the functional tissues of an organ, and that in fluids. And so they suggest that the difference between the group's fluids may be due to the underlying differences in the parenchymal levels of adults versus infantiles or infants or juveniles. It is also known that GFAP levels are elevated in the brain lysates of Alexander disease patients. Another thing of which they're uncertain is the origin of extracellular GFAP, and they suggest that this could be due to astrocyte death or increased plasma membrane permeability. And then finally, they addressed the limitations of their study, and one of the large limitations they suggested was age matching. And so they're only able to collect the blood from control subjects who are greater than 18 years old. But 27 of the 48 Alexander disease patient samples were below this age. And so this may have caused an issue because there's such a disconnect between the age, but previous studies have found that GFAP levels in CSF and blood had no relation to age or sex. So this may not be as big of an issue as it may seem. And then another issue that they had was they only had access to leftover clinical samples, so they may have varied considerably with respect to the interval between collection and freezing. And then finally, they only examined samples taken at one time point during the disease process, and because of this, they cannot reach any conclusion about how GFAP levels might change in an individual during progression of the disease. And then also, for the Alexander disease patients, the CSF and the blood samples were taken at different times, so they cannot establish any direct connections between the GFAP levels in blood versus the CSF. And so, despite all of these limitations, which all studies have, the authors have found results that create a foundation for future studies aimed at developing appropriate biomarkers of disease severity, progression, and responses to treatments. And so hopefully, thanks to this study and confirming Keilerman's results, we can work in the future to create treatments for Alexander disease patients and improve their quality of life. Thank you.